Good morning, everybody. Thank you for joining us. My name is Julie Kornfeld. I'm the Vice Provost for Academic Programs here at Columbia University, and I am joined by an esteemed panel of leaders here at Columbia who have been working incredibly hard for the last almost a year to keep this community safe. So thank you for your interest in joining us and being on this town hall. I'm going to introduce you to the three panelists who will begin and do a series of brief presentations. And then we will have a period of time for questions and answers. You may also feel free to put your questions in the Q&A box at the bottom of your screen, and we will also try and answer those throughout this session. So I'm going to start by introducing our three speakers, and then we will move from one to the other. But I want to, we have done a series of town halls across Columbia University with these three esteemed leaders, and they have been working incredibly hard to keep the community safe, and feel very fortunate that they have joined us today. So first, Dr. Wafa El-Sadir, who's a health researcher, university professor, and medical epidemiologist, and also the director of ICAP here at Columbia University and the Mailman School of Public Health. She has played a critical role here at the university, leading the COVID efforts, as well as with the New York City's mayor's office and his scientific advisory counselor, the New York City Test and Trace Group, and a leadership role in the Columbia University COVID-19 Task Force. Our second speaker will be Dr. Donna Lin, who's the Senior Vice President and Chief Operating Officer of the Columbia University Irving Medical Center. Prior to joining Columbia, she was Colorado's 49th Lieutenant Governor and Chief Operating Officer, and has played an integral role in our vaccine rollout here at Columbia. And our last speaker will be Dr. Melanie Burnitz, who is now Senior Vice President for Columbia Health. Dr. Burnitz joined Columbia Health in 2016 and has served as its Associate Vice President Medical Director until just this month, where she was named the Senior Vice President, and we're thrilled to see that. And again, I'll be your moderator. Please use your Q&A box, and I'm going to turn things over to Dr. El-Sadir.
And thank you very much, and good morning and good afternoon and good evening, everyone. I'm going to start by sharing my screen. And Julie, can you see the screen?
Yes, I can.
Okay, let's get started. Okay, what I'm going to start today is to give you a sense of where we're at in terms of the status of the COVID-19 pandemic, as well as the status of the vaccine development. And just to summarize it in one phrase, we are now in a race between the virus and the vaccines. So what's been going on around the world? As many of you are aware, we have continued increase in numbers of COVID-19 cases around the world, with now more than 100 million cases reported globally. As you can see from this map on top, on the upper right-hand corner, is that that COVID-19 has impacted every country around the world. When we look by region, the majority of reported cases have been reported from the Americas and from the European region. And then at this map here in the lower right-hand corner, this is what's happening most recently. This is the number of new confirmed cases per million population. And this tells you that the impact, again, is largely most severely in the Western Hemisphere, in the Americas, and then in parts of Europe in particular. And then now beginning of substantial concern about what's going on in sub-Saharan Africa, particularly in Southern Africa. Now, what about what's happening in New York City, which is important, obviously, because that's where Columbia is situated. In continuing increase in numbers of cases, now more than 608,000 cases have been reported, with more than 27,000 deaths. And New York City is experiencing the second surge in the pandemic, with the first surge having occurred last March and April. But we're optimistic that we're beginning to see some plateauing in terms of the daily numbers of new cases, but still at a high plateau of more than 5,000 new cases per day. And also with about between 8 and 9% positivity in terms of COVID-19 testing. I'm going going to switch now, and after this brief introduction, and focus on vaccines. Where are we at in terms of vaccine and vaccine development? The good news is there are several vaccine candidates that are already in development, going through the usual traditional phases of research in terms of phase 1, phase 2, phase 3 research to determine whether these candidates are efficacious, meaning do they work, and whether they are safe. Thus far in the US, we have 2 vaccines that have been approved, but there are several other vaccines that are available globally, and I'll touch base on that shortly. Now, this is the status of the leading vaccines that are available around the world. And as I mentioned before, the 2 vaccines, the Pfizer-BioNTech vaccine and the Moderna vaccines, these 2 vaccines are the only ones that are available currently in the United States for use, and they use the same technology, mRNA technology, and you can see that they have also been approved in several countries around the world. There are several other vaccines that are, again, that have been leading the way. I'll touch base on some of them, and we do have some late-breaking results in terms of the results from Johnson & Johnson Janssen vaccine, as well as the Novovax vaccine. I'll provide some updates in terms of where these vaccines are at. But you will notice that, again, that these vaccines, various types of vaccines are available in different countries around the world, and this is changing on a daily basis. So let's start by the 2 mRNA vaccines, which are the 2 that are available now for vaccination in the United States. These 2 vaccines have been stupendously effective. They are they work really well, and they showed in the 2 studies that were done that they were Pfizer-BioNTech at 95% effective, and the Moderna vaccine 94% effective. The good news is in terms of safety, there were no serious safety concerns reported with either of these vaccines. And importantly, that both of these vaccines require 2 doses to be delivered several weeks apart in order to achieve the optimum protective effect of these vaccines. There are other vaccines that are available around the world, and I'll touch base on some of them. One of them that some of you may be aware of is the Oxford Astrazeneca vaccine, and this uses a different approach of actually taking a fragment of the SARS-CoV-2 virus and then using a chimp adenovirus to stimulate the immune system. And this vaccine has had varying efficacy based on the studies and where they were done. It ranged from 62% in one study to 90% in another study. And at this point in time, there are further studies that are ongoing. There's one large study that's ongoing in the United States, and we await the results from the AstraZeneca Oxford vaccine study here in the US. Nonetheless, this vaccine has been authorized and approved for use in several countries and is being used widely, for example, in the UK, amongst other places. Similarly, no serious safety concerns were raised. Most commonly, again, the same thing. All of these vaccines, the most common side effects are at the injection site with some tenderness, swelling, or redness at the injection site, but no serious side effects. There's another vaccine that's been used also globally, and that's the Malaya Sputnik 5 vaccine. And that also uses this adenovirus, the idea of these very benign viruses, to use them to introduce part of the virus itself to stimulate the immune system. And the data that we have available, what we've heard is that it's 94.1 effective in preventing COVID-19 disease as well. And similarly, there have been no serious effects that have been reported from the reports that I have seen on this virus. This vaccine as well requires 2 doses. There are 2 vaccines from China, Sinopharm and Sinovac, and these use a technology of actually inactivating the virus itself, meaning killing the virus, and then using killed virus, which is good, that's safe, killed virus to induce immune response against SARS-CoV-2. And again, the efficacy of these vaccines have ranged for the Sinopharm vaccine from 79% to 86%, and for the Sinovac from 50% to 78%, based on the studies that have been reported. And again, the safety profiles appear to be similarly quite reassuring in terms of these 2 vaccines as well. And again, these 2 vaccines require 2 doses. Now, just the day before yesterday, there were the release of at least a press release on a new another vaccine, which is the Johnson Janssen vaccine. And this is an exciting development because this is the first vaccine that requires only one dose rather than two doses, which of course makes it much simpler to implement. And this also uses this technology of adenoviruses, these cold viruses that are benign, that are used to generate the immune response. And in a large study of more than 43,000 participants from all over the world, 44% from the US, 41% from Latin America, and 15% from South Africa. And again, the endpoint for the study was the prevention of moderate to severe COVID-19 disease. And the vaccine was overall found to be 66% efficacy. However, there's a range you'll see here across where the studies were done, with a high efficacy of 72% in the US, 66% in Latin America, and in South Africa, 57%. The important thing to note is that the vaccine, according to the press release, appeared to be particularly effective in preventing severe disease, 85% efficacy, and that seemed to be consistent across the three regions where the vaccine study was done. Similarly, there were no serious adverse or side effects that were noted with the use of this vaccine. So in addition to the fact that this vaccine requires one dose, which is really important in terms of scaling up, this vaccine also can remain stable at regular refrigerator temperature for several months. So this allows for the potential of scaling up vaccination in remote areas, in rural areas, as well as in settings where having very low temperature freezers may not be available. Now, what about the Novovax? That's the other vaccine. The results were released last week. And this it's a protein vaccine, so it uses a different mechanism, but it's similar to what's been used before in terms of influenza and papillomavirus vaccines. And this study was also done in large numbers, 15,000 individuals. It's a two-dose vaccine again, and it has an efficacy was shown of 89%. However, in a smaller study that was done in South Africa, the efficacy dropped to 49%. What's important is that they found that in the study in South Africa, and similarly in the Astrazeneca study, is that many of the cases, if not almost all of them, were involved the new variant, South Africa variant of the SARS-CoV-2 virus. And I'll touch a bit on these new variants. So that's where we are in terms of vaccines, but literally every day there are new data that are arising in terms of new vaccines that are coming online and hopefully will be soon authorized and approved by various countries around the world. So this is what's happening in terms of global effort for COVID-19 vaccination. And this is per 100 person. You can see here from this map varies substantially with a high of greater than 50 persons per 100 person vaccinated to, of course, you can see here much lower rates of vaccination. And the darker the blue means the higher the rate of vaccination in the countries with the darkest blue. Obviously, you can see right away that there's some parts of the world where there has been no vaccination, like, for example, many of the countries, almost all the countries, actually all the countries at this point in time in sub-Saharan Africa. If you look by country, there are some countries that have done exceedingly well in terms of the scale-up of vaccination. For example, again, Israel has been vaccinating rapidly its population. United Arab Emirates is another place that, again, has been vaccinating population very briskly, followed by the UK, Bahrain, the US, and you can see here the different countries and, for example, European countries like Italy, Germany, and France, as well as China, Russia. And then India is beginning a massive national vaccination campaign to reach its very, very large population. So overall, up to now, up to January 30th, the total global numbers of doses administered has reached more than 94 million doses of any of these vaccines. However, what's important, and this is an issue of equity, is to track, of course, by continent. And you can see here from this figure is that the majority or the doses administered have been in North America, in Europe, and then Asia, South America, with none in Africa or Oceania. So as we're scaling up vaccinations in the countries where each of us are situated, it's also important to keep in mind that ultimately the goal is to scale up globally so that we can prevent the emergence of new variants. And also we can, of course, because of transmission of this virus, we can prevent transmission from individuals who are moving across countries and within countries. Now, this just shows you, and this again changes by the minute actually, of where each of the vaccines are being used. And not surprisingly, the Pfizer BioNTech and the Moderna have been largely used thus far in North America as well as in Western Europe, with some other countries in the Emirates, for example. And the Astrazeneca vaccine has been used as an example in the UK, as well as you can see here in Brazil and in India as well. But you can see also that some of the other vaccines are being used in specific countries around the world. But nonetheless, I think the message from this slide is that we have a long way to go in order to scale up appropriately within countries and across the various countries of the world. I'm going to touch a bit on these variants because now we're concerned about this, what's going on, transmission of SARS-CoV-2, but also with these evolving new variants. And by new variants, this means this is because of mutations that occur in parts of the virus itself. So you can see in this figure on the right that in orange here is one mutation, a change in the structure of the virus that occurs, and this has been noted in the UK and the variants from South Africa and Brazil as well. And this is in what's called the spike protein of the virus, and it is exactly that part of the virus that latches on to the receptor, the human receptor in our lungs and so on. And that's why any mutations in this part of the virus can potentially compromise the effectiveness of some of the vaccines that are under development. So it's of great concern. There are multiple variants that are now circulating globally. Probably the one that most people have heard about, the one identified in the UK, and now in many countries around the world, which has been noted to be associated with increased transmissibility and is responsible for the vast majority of new infections in the UK. There's also the South Africa variant, which again circulating in 31 countries, and I showed you some of the data from the new vaccines that show a diminution of efficacy in some of the studies that were done in South Africa. Then the Brazil variant and the several US variants that are now widely circulating. So the issue is, what can we do to stop more variants from evolving? And the one thing is to stop transmission as much as possible, because each time the virus moves to a new host, that in a way gives it the opportunity to mutate and result in some of compromising some of the treatments and prevention tools we have. What are the implications of these variants in terms of the testing itself? Actually, there's the good news is that these variants don't compromise the PCR testing or the antigen testing for this virus, for SARS-CoV-2, which is good news thus far. However, we're concerned about the impact of these new variants on vaccines as well as on treatments also, particularly these new treatments, these monoclonal antibodies that have been developed that look so promising in terms of treating and preventing SARS-CoV-2. It appears from early data that these variants may again, although not totally outsmart or escape the vaccine and the treatments, but nonetheless, they do have an impact on how well these vaccines and these treatments work. So let's move on to fundamentally what needs to happen next. As I mentioned earlier, in order to achieve the impact of vaccines, of any vaccine, or any intervention actually for that matter, any medical, any treatment, any prevention intervention, we need to, of course, start with an intervention or vaccine that has high efficacy. This is very important. And we're fortunate with some of the vaccines that have been developed thus far. They actually are really very highly efficacious, means that they work, they really work very well. So that's fantastic. That's really great. It's always very important to use vaccines that have the highest possible efficacy of all the options available to an individual or to a country. Then probably the biggest challenge is in achieving high uptake and high coverage. And this means that the importance of very quickly getting the vaccines and getting people vaccinated, particularly people who are at highest risk for getting SARS-CoV-2 infection. So the goal should be to get as much as possible the vaccine with the highest efficacy, and then to rapidly work to getting those most at risk to be vaccinated. Now, in general, who should be the people who to be prioritized for vaccination? And I think of them in two categories. The first category is you need to go and vaccinate the people who are at highest risk for infection. Very important, so you can protect them and prevent infection transmission. And that includes healthcare workers, essential workers like grocery workers, transit workers, as meat processing plants, for example, in the US. There's certain race and ethnic groups that have been noted to have high rates of transmission. And then people who are residents or work in congregate settings, meaning long-term nursing home facilities, homeless shelters, prisons, etc. The other group that's really important to vaccinate early are those individuals who are most likely to have a higher risk of getting complications of COVID-19, having high rates of morbidity, we call morbidity, which is illness, severe illness, and mortality deaths. And that includes older individuals, people with comorbid conditions, meaning chronic medical conditions like diabetes, heart disease, obesity, lung disease, high blood pressure, and also pregnancy, again, because it's been noted that pregnant women are at risk for more complications if they get infected with SARS-CoV-2. Now, who's currently eligible for vaccine in New York City? It's, again, the highest eligible group. You're not going to be surprised. Healthcare workers and residents and staff in long-term care facilities, as well as the populations that I just mentioned in the previous slide, who are those that are at highest risk, as well as those, as you can see here, these groups are at highest risk, but then also people at highest risk of complications associated with COVID-19, which are older individuals. The next eligible groups in the future will be going down the line to go to less to people on the list in this phased approach. And this will include going to other frontline workers, other groups at risk, going to individuals with comorbid conditions, and so on and so forth, until hopefully we can reach the vaccination of the full population in this country and around the world. What's of concern is what's been reported is that what you worry about was that with expansion of vaccination, that people will let go of their vigilance and the other protective measures that we call the non-pharmaceutical interventions, meaning the wearing of masks, the distancing, which is very important, avoiding large groups of individuals, and so on. And what we've noticed, at least in the US over time, which is of great concern, is that there's a decrease in terms of people who are utilizing these protective measures. And that's of great concern. And of course is of concern in the context of vaccines, because that we're worried that in the context of vaccines, people may let go of these protective measures. So I end by summarizing that we need to continue with all of our preventive measures post-vaccination. This includes, this is for the reason that the protection from a vaccine is not immediate. No vaccine is 100% effective. The duration of protection is not known. We also have limited information as to whether the vaccine prevents asymptomatic infection, and that everyone in the meantime needs to continue to practice all of the guidance that have been in place and that are in place until we can hopefully see the end of this pandemic. I want to thank you very much, and I'll
thank you.
To
we're going to turn to Dr. Lin as our next speaker. Thank you very much, Dr. Elsteer.
Good morning, everyone. Can you see my screen? Yay, yes. Okay. Well, as Wafa said, wherever you are, welcome. It is snowing quite hard in New York, hence my background, although that's not New York. So I'm going to cover a few things that Wafa covered just to reinforce really what's going on in New York. I know many of you are probably keeping your eye on it. We do work with Safwan, who is not able to join us today, and a whole group of university representatives to work on opening up the global centers, to expand the WeWork facilities so that you have places to do your work and to congregate to the extent that we can do that using physical distancing. But there's a lot of work that's been going on campus for literally now almost a year, including a task force that the provost leads, where we, throughout the first probably 6 months of the crisis, met daily, and we've cut that back, but there's a lot of work going on to bring students back to campus. And I want to give you a little bit of a picture, and I'm sure Melanie will as well, that what life will look like when you're able to return to campus. And we're all really looking forward to that. So, okay, I can't go to the next slide. Let's see. There we go. So to give you a little bit of a flavor of what's going on in New York, as Wafa said, we are in a new surge, certainly not similar to the surge that we had in April and May of last year, but nevertheless, somewhere between 5 to 9% is the rate of positivity that we're having in New York State. We watch New York State just because the governor certainly sets a tremendous amount of the policies around what can be open, how classes are done, how universities and other businesses respond to this crisis. So we've seen restaurants open and close. We were able to open up Dodge for some recreational activities as of last week. We've got restricted gatherings on campus, but again, as Wafa said, the race between the virus and the vaccines is one that we hope by the latter part of the spring, we will have won on a scale that allows us to return much more to a campus life that you're familiar with, hopefully in the summertime. You can see the number of cases in New York State, which is 1.4 million cumulatively and just about 600,000 here in the city. The deaths are overwhelmingly in the over 70 and over age 70 category. Wafa shared this map. I want to go a little deeper because it's important that you look at Manhattan. We measure not only what's going on in the city, but what's going on our various campuses. The good news is those are lower rates of positivity, but still concerning enough that we keep our density at 50%. We ensure physical distancing, face covering, and the like. For me, on the medical center campus, we watch hospitalizations around the city, and at New York Presbyterian, who's our partner, are at a concerning level. Again, nothing like it was in April when we saw our peak. We're seeing a slight leveling off and hopefully a reduction in that trend. We've emptied out the dorms, as you know, on our campus, on the Morningside campus, the dorms are open with reduced density, but we're starting to house non-Columbia affiliates who are predominantly the military who are helping us out with healthcare, both vaccinating as well as healthcare in the hospital. And this is just a picture to show you the trend that I described that's been accelerating really since sort of the middle of November, some of it as a result of some of the social gatherings. And I'm sure Melanie will share with you some great work that's being done to prevent transmission across the campus. Our testing program, which we'll go into more detail, has been nothing short of spectacular. Students are required to have testing now twice a week if they're undergraduates. And the positivity rates are well below the community. I'll skip over these because I know Melanie will go into a little bit more detail. As Wafa defined, we moved by December 15th into a vaccine implementation plan. And the rules, and I know a couple of the questions related to, where you live and what some of the rules might be for spouses and the like. The state of New York has created a lot of the rules around vaccination. And much like the vaccine availability and distribution has changed minute by minute, that's happening in some cases with respect to the state rules. So the state has defined certain categories and then redefined them. So right now, if you're 65 or older in New York State, you can get the vaccine. If you're a healthcare worker, and if you are in certain public-facing activities like in-person teaching, public safety, and public transit. There's 7 million people in that category, and we are only getting 250 to 300,000 doses a week, which means it's well into April. If that's the supply that's going to be available, we're well into April before we can get to other populations, including people who have underlying medical conditions. So we're often asked when students might be eligible. If the supply continues at this rate, we're really talking about probably early summer. We are working very hard. As you saw, Wafa said, there are 2 vaccines that are now available, both the Pfizer and the Mrna vaccines. We're also vaccinating not only our own employees, but also people in the community. At the Armory, those of you who are familiar with the Medical Center campus, the Armory is across the street. It's an indoor track, and we're vaccinating around 3,000 people a day in the Armory. We're over 41,000 first doses. So just to give you a sense of the scale of this, we've administered over 30,000 doses now at the Armory for the public. And we're very focused on the Washington Heights community, which actually fits into a category that, as you know, many of the residents in Washington Heights, we've seen a higher positivity rate, and we've also seen a greater incidence of death. And one of the main things that we're working on is trying to make sure that we support our community. One of the most frequently asked questions, and again, Melanie will probably go into this, we do this testing on both the CYMC and the Morningside campus. It's called to determine whether or not you're positive. And oftentimes people who've gotten the vaccine say, well, I don't have to go through testing anymore. That's not true. We'll get to one of your questions in the chat box, in the Q&A box, excuse me, later. But you still must go through, once you return to campus, and we anticipate the testing is going to go well into the summer, you do need to continue to get the testing. So I'm giving you a few websites that will be helpful for you. One is vaccinetogethernewyork.org. Another is our Columbia COVID-19 website. And then for many people, vaccinations, although we would love to provide them at Columbia, it's going to depend on what the governor and the mayor do in terms of distribution. And so there are city-run sites that you can also access as well. So with that, I'm going to turn it over to Melanie. And just a reminder, you can put questions into the Q&A box.
Thank you so much, Donna. And let me share my screen. And good morning, good afternoon, good evening to you all, wherever you're joining us from our snowy New York. I'm Melanie Burnitz, and I oversee student health for the students on the Morningside campus. So hoping to share some more local updates with you today, just so you can see what's happening on campus and see how these translate to wherever you are in terms of protocols and policies. So you've seen a lot of the global and the New York data. This is our campus picture, and you can find this data on the covid19.columbia.edu website. And it's certainly better than the New York City situation that you've heard described. As Donna mentioned, we've done many tests. Since June of last year, we've done over 135,000 tests, and our cumulative positivity rate is less than 0.5%. Over the last 3 weeks on campus, we've done over 35,000 tests with a slightly higher positivity rate, but that was expected as people came back from international or domestic travel, from family visits over the holiday, and actually is the exact reason why we did such intense testing at the start of the semester to really detect positive cases before accessing campus. And as I'll describe in a moment, we're also tracking our positive cases with contact tracing across all of our campuses. I'll share a little more about that in a moment. Our community has become very familiar, and I'm sure wherever you are, you've become familiar with these safety protocols as well. For those who've been on campus, we say it's a new year, but it's the same compact. And for those of you who will be returning to campus, it's actually quite simple. And as I mentioned, these measures apply whether you're on campus or if you're studying at a WeWork site or a global center. And we know that despite all these exciting advances with vaccination and testing, it's actually these simple measures that are keeping us all safe. So we constantly reinforce them: keeping a distance, wearing a face covering or a mask, and staying home if you're sick. We have a health and safety policy and the Columbia Community Health Compact, and these together recognize that we all have a shared responsibility for community health that's deeply informed by science and founded on our mutual respect for each other. And we all know that we're operating differently now than we did pre-pandemic, that these changes require new habits and sometimes very difficult adjustments, but we know that these life changes are essential for our ability to be together as a campus community. For those of you on campus, this daily attestation, I say, has become as familiar as brushing our teeth in the morning. We do this every day. We've adjusted this daily attestation, and this is the Reopen CU app. So if you do come back to campus, this is the app that you complete every day before coming to campus. And it allows us to evaluate whether or not it's safe for us to come to campus every single day. It allows us to answer questions honestly. And then if we are safe to come to campus, we get a green pass. And if we're not safe because maybe we've been exposed, we're feeling unwell, we've recently traveled, we'll get a red pass and guidance about what to do to stay home and when we can return to campus. Below the submit button on that daily attestation is also a checklist. And this checklist shows the required things that we have to do before coming to campus, which includes the training, the compact, our testing program, and for students, participation in our mandatory flu vaccination program. We have a lot of lessons learned, and I share these with you because these are relevant wherever you are studying. And we've learned a lot of this through our contact tracing, which has shown us where COVID spreads. So one of the biggest ones is not staying home if you're feeling unwell. Obviously, if you have symptoms, if it's COVID or something else, you're putting other people at risk. We know that our professors, our bosses would all rather we took extra care and stayed home rather than coming to work or to school. The other important ones to emphasize are the appropriate physical distancing. We know, and losing that 6 feet physical distancing or that 2 meters happens most frequently when people are eating together. They're taking off their masks, they're sitting close. We know we all want to eat together. It's a social activity, but if you do so, please keep that 6 feet distance. And then a lot of our sites have been transformed. There's signage on seats and there's setups of tables differently to keep 6 feet apart. Our instinct is to move closer together, but we ask that you don't do that. You keep that distancing. Donna mentioned the great resources available, and I highlight again the covid19.columbia.edu website. I would suggest you bookmark that site. And if you have any question about what's going on around testing, tracing, vaccines, so much more, education, plans for the spring and the summer, go to the website first. There are numerous FAQ pages. There's actually even a chat bot so you can post your questions, and we post our real-time data once a week, so you can go there. So I did want to share a little information about our testing program, which, as Donna mentioned, has been quite robust. And this has been in place since last summer, and we've evaluated it continuously. We're so fortunate to have input from many of our Columbia experts, epidemiologists, modelers, statisticians, infectious disease specialists, public health professionals. And we've created a very flexible and adaptable program that really responds to the situation both on campus and in New York City. So we constantly adjust this. We've also created 2 large-scale, high-throughput testing sites, one at the Morningside campus at Lerner Hall and another at the Medical Center at the Black Building. And we routinely were able to do 3,000 tests per day across our testing sites as we need to. So the first requirement for everyone returning to campus is what we call a gateway or a re-entry test. There's nothing special about this test. It's just the first test that you take when you come back to campus. Many of our community who's on campus completed this by January 25th. Anyone who's not completed it so far will automatically have a red pass on their app and won't be able to access campus until that test is completed. For obvious reasons, that way we'll know everyone's status before they come back to campus. So if you are planning on coming back at any stage during the spring semester, you should schedule that first test to allow you campus access. Once we do that first gateway or re-entry test for everyone, we have an ongoing surveillance program. And this, we learned last fall, has been really imperative in our ability to track the prevalence of the SARS-CoV-2 virus on our campus and make broader adjustments to our public health protocols. So we encourage everyone to get regular testing. For our undergraduates, as Donna mentioned, who are living on campus, they're getting testing twice a week. And for everybody else, we really strongly recommend weekly testing. In addition to that, we are randomly surveilling 10% of our population a week. If you're invited, and that's only obviously for our population who are accessing campus, and if you're invited to get that test, it is mandatory. But for everyone else, you're welcome to the weekly testing, and this can be done if you need to, if you're returning from travel, if you're planning on traveling, or just so you know your status on a weekly basis. The one caveat we have for testing is that we don't do symptomatic testing at these large testing sites for obvious safety reasons. But for all our students, testing is available at the Student Health Services on campus, and at the Morningside campus, we have access to rapid testing. So for our students with symptoms, we evaluate them, we test, and we can give them a result within 15 minutes. So our testing program has been paired with contact tracing, which allows us to really quickly identify, contain, and suppress transmission of the virus. So once someone is diagnosed with COVID-19, we interview them and we ask them about anyone they came into contact with while they were infectious who meets close contact definition. And then we advise those individuals to quarantine for the 10 days. This program is completely confidential. So we don't reveal anyone's identity unless they ask us to do so. And this team was created in partnership with Columbia Health and ICAP at the Mailman School of Public Health. And we have a very robust team of supervisors and contact tracers who are working 7 days a week across our campuses to rapidly contact trace. We've set up a hotline and an email address that you can see on the slides here. So anyone who is on campus or near campus and tests positive can let us know so that we can activate contact tracing. So quarantine and isolation, what's the difference? We often get asked this. Isolation is where we separate someone who's diagnosed with COVID-19 from the rest of the population. And this person isolates for 10 days and until they have no fever for at least 24 hours. Quarantine, while the timing is the same, it's also a 10-day quarantine. It's the separation of healthy people who've been exposed to see if they become sick. And there's two main reasons that we're quarantined. One is obviously if they have a close contact, as I just described, someone who is positive and they're a close contact. And the second is return from travel. New York State has changed the travel guidance and it is listed here. There's also links, and I'm not going to go into the detail, but if you are returning to New York from an international destination, you are advised to get a test 72 hours before your departure, a negative test, and that is required for travel as well. When you arrive in New York, you'll be required to quarantine for 3 days, and then on day 4 to get a test. Once you have a negative result, you can then leave that quarantine. If you're unable to do that testing, you do have to quarantine for 10 days on return. It's a lot of information, so all of these travel restrictions are on the website. Okay, just one, we've answered a lot of questions in the chat about the vaccine. And the big question, as the other speakers have mentioned, is when are we going to get vaccine? We do not yet know. No universities in New York State have been given a vaccine allocation. Columbia has applied. We have been accepted as a vaccine provider, but obviously we have to wait to get through those 1A and 1B categories that Donna described to see when we get a vaccine. But be assured, when we get vaccine, we have a plan to distribute it. If you've been on campus before and gone through any of our flu fairs, you know that we're used to doing mass vaccination and mass distribution. So when we have an allocation, we will be distributing it to our Columbia population. So just stay checking the website and we'll continue to post there, and we'll certainly message our population when it becomes available. And just finally, also on the website is our monitoring plan, because the situation changes so rapidly. Be assured that we are looking at all these different variables, both what's happening around the city with infection rates and hospitalizations, and on campus using our testing and tracing programs that I described, so that we can see what adjustments we need to make for our campus, around classes, around gatherings, around events, around dining. So we have a 4-phase monitoring plan. Again, this is all spelled out on the website, and this way we can adjust as we need to in real time. So it allows us to fluidly move depending on what we're seeing. And my last slide here is a reminder that we have extensive resources for our community, whether you're a Morningside student, a CUMC student, and whether you're on campus or you're overseas. Many of our services, as a reminder, are available virtually as well as in person, including medical and counseling, health promotion, disability services. There are a lot of offerings. There are a lot of support spaces for our students. So please go to the website, both for Columbia Health and CUIMC Student Health on Haven, so you can see the services that are available to you. And I'll stop there. I hope you've gotten an indication of the extent of our programming. And thank you for your attention. I think we're ready to go to questions.
Yeah. Julie, one thing I'd add to the great presentation that Melanie just gave is one of the things that we're trying to do, and we do this in combination with Columbia Global Health, is to take some of the rules and requirements that we have on the campus and then apply them, but also adapt them to what's going on internationally. So we look on a weekly basis at conditions in the countries where we have the global centers or we have the WeWork arrangements, so that we make sure things like the symptom self-checking app, density rules, et cetera, are applied, again, with some consistency, but again, we know that there are variations in terms of the public health conditions across all of the countries. The second thing I just add, and I think there were some great questions in the Q&A box, and maybe a couple of them bear repeating, is that not only is the situation in New York City evolving rapidly, but there are a lot of rules that we have to follow. And so initially when we started doing the vaccine, we could vaccinate anyone. We meaning the supply went to New York Presbyterian. Columbia worked very closely with them, staffing facilities, getting our patients in, getting our employees in. But at first, the rules were you could vaccinate anyone. Within about 2 weeks, that changed to you could only vaccinate people who lived in New York State. And then within another week, the rules changed to you could only vaccinate somebody who had a New York City address. That's the current rule. What we don't know, and that's partly because of the way the vaccines are being distributed. If New York City publicly receives X amount of vaccines, but then we show that Y amount of residents got it, it looks as if New York City's not performing well. So this issue of where your residence is or what your address is one I think that we're going to continue to have to sort out, particularly as we get to students. And in the worst case, where, as Melanie said, we would like to have the vaccine available at Columbia Health and at other locations so that we could take care of our own affiliates. In the worst case, what we will, if we don't get the vaccine because the city has other distribution plans, we'll work to make sure that we can vaccinate students through other locations and give them some preferential, might be too strong of a word, but we certainly want to be mindful of the importance of vaccinating our affiliates. And even if we don't have it, we're going to work to make sure they get scheduled in some of these larger distribution areas. Julie,
I want to also, yeah.
So go ahead. Go ahead.
I mentioned one other thing that for Melanie's, our app that we use on campus, and I'm this community that we also have an annotation app that's designed specifically for the international student community who are accessing the global centers and the WeWork sites. So while you are abroad, that app was designed for your use. So that we can, in a very similar way, monitor your health as you're accessing the global centers and the WeWork sites. And you have received, I know, information through the many communications, but continue to monitor that and continue to monitor, I think, as Melanie said, our website, which is available to you and provides up-to-date information for you as soon as we have it here. There have been several questions, and I want to, I think, several questions, and maybe, Wafa, you might want to just reiterate to the group.
You're breaking up, Julie. I can't hear you.
We lost you. You froze, Julie. I think she was trying to direct some of the questions, Wafa, that went to you that were in the chat box.
Can you hear me now?
Yes.
No. For 1 second. You know, one question, and I'm going to ad lib a little bit. One question that we've gotten that I know WAFA has answered in other groups is, if you get 1 dose of a vaccine in your home country and you come to Colombia, would we give you the 2nd dose? And WAFA, why don't you expand on that?
Yeah, I think that it really behooves everyone to get the full regimen of the vaccine that they have received. So if you've received, or someone has received the full dose of one vaccine, you should really try very hard to get the 2nd dose of the same vaccine. Because the data we have in terms of how they work and the efficacy data that I showed you is really dependent on getting 2 doses. We have no idea as of yet whether it's safe to mix and match different vaccines, and also whether it is beneficial to do so. So as much as possible, if you started a regimen, if you've been vaccinated with 1st dose, please get your 2nd dose before you come to the United States, for example.
In fact, we often will not give 2nd doses to people who have not gotten the 1st dose with us. I get those questions every day. You know, somebody went to a public site. The appointments right now, and hopefully this won't be the case in the summer, are very, very hard to get. Some facilities, you know, cancel their appointments because they're overwhelmed or there's a problem with the computer system. So just to re-emphasize, stay in your home country, even if it means delaying your planned trip. You can always do classes remote and virtual, but don't come here expecting you can get a 2nd dose.
I think maybe to add one thing to what Melanie said is that in addition to continuing to observe the same behaviors that we mentioned after getting vaccinated, also it's necessary to continue to comply with the testing program, so that for people who got vaccinated, they should, and they are here and they're accessing the campus, they should continue to observe the Columbia testing program.
Wafa, could you talk a little bit about side effects?
Yes, I can. I think we have some full data from some of the vaccines, and probably the most comprehensive data from the Pfizer-BioNTech, the Mrna, and the Astrazeneca vaccines. And side effects from vaccines are from all vaccines, other vaccines as well, usually happen in the period immediately after vaccination. So it's very different from drugs, where sometimes you can have early side effects and late side effects. With vaccines, the side effects are usually, if they're going to occur, they occur in proximity to vaccination. And then there are 2 types of side effects we think about. One is local side effects, and those are right where the person gets the injection. And another type of side effects are systemic side effects, which are not at the site of infection. With these vaccines that I mentioned to you, the most common side effects that have been reported have been the local types of side effects. And the good news that even those have been mostly mild to moderate side effects. Like I said, some soreness, some tenderness, and also maybe a little bit of swelling and redness right where the injection was. And then these, again, like I mentioned, none of them have been severe in those studies. In addition, the systemic side effects that have been reported have been, again, mild to moderate again, and could be headache or fatigue or fever. I think one of the major concerns has been about allergic reactions after getting a vaccine, and I'll touch on this. So there's the issue of severe allergic reactions, and these usually happen within half an hour after getting a vaccine. And in anyone who has a history of a severe allergic reaction, what we call anaphylaxis, it's recommended they must get the vaccinated in a clinical site. They must also inform the person who's vaccinating them that they have a history of severe allergic reactions in the past, because they need to be observed for a longer period of time, for 30 minutes instead of the usual 15 minutes. And somebody needs to keep an eye on them during this critical half an hour after they get the vaccination. Fortunately, these types of severe allergic reactions have been rare, at a rate of about 11 per million vaccinations.
Wafa, we had a question in the Q&A box about the frequency after the initial 2 doses, or if people end up getting a 1-dose vaccine, are they going to have to keep getting this every year?
We don't know. I mean, I think some people think that this coronavirus may become seasonal, like similar to influenza, which comes back every year. And every year we essentially manufacture a new influenza vaccine based on what are the variants that are circulating in the world. So there's some who believe that if this is the case, if this is what's going to happen with this coronavirus, then it means that even people who are vaccinated now may need to get another vaccine next winter, for example. I mean, the good news again is that the development of vaccines for coronaviruses is not complex. It is very different from efforts to develop a TB vaccine or an HIV vaccine, where we've been working for decades and decades trying to develop those. These coronaviruses, it's pretty straightforward to develop the vaccines, and that's why we have so many candidate vaccines. So I think even if we need to get seasonal vaccination, I'm confident that the companies would be able to mobilize and produce such a vaccine in a timely manner for the annual vaccination.
And Wafa, maybe one quick question, because we're getting close to time and closing out. Can the Sino vaccine side effects do they prove that the vaccine actually works?
Not really. I mean, people have been saying, for example, some people have said, oh, I got a very, my arm really hurt and so on. It means that my body's responding to the vaccine and I'm better protected. We don't know that actually for sure. I think, and I'm distinguishing here what happens at the local injection site, which is what we call reactogenicity, which is reaction of the body to the immediate injection, which is likely related to but different from immunity, protective immunity. So we don't really have a one-on-one correlation, a one-on-one association between the side effects you develop and how well the vaccine works.
Great. Well, thank you, Wafa, and thanks, Melanie. I'm going to speak on behalf of Julie because she's frozen a few times. But thanks, Julie, for organizing all of us and for all of you who participated. This will be posted on the web. And we obviously look forward to welcoming all of the international students back to the university on site. So thank you, everybody.
Thank you. Have a good day.
Thank you. Thank you, everybody. Thank you.
Thank you.